Welcome back to episode 3 of the Rehab, Exercise, and Sports Therapy podcast. I have with me today Caroline, formerly Bertram, right? Now Guglielmo. I apologize. My Italian is not great, so if I butchered the name.
Pretty good.
All right, excellent. Good. So Caroline, I'm also going to apologize. I'll give the disclaimer that I am on hotel Wi-Fi at the moment, so hopefully you can hear me okay, and hopefully this doesn't come across too choppy. But Caroline is going to talk to us today about sports concussion rehab, something that I admittedly know very little about. I can kind of usually bluff my way through shoulder, hip, and knee, but sports concussion is something that I am definitely excited to learn more about because I am not very well versed. So Caroline, if you could give us a little bit of background about your bio and what you're doing right now, how you ended up in this little niche.
So I'm a physical therapist. I got my undergraduate from Sacred Heart University, came back to Rhode Island, which is where I'm from, went to URI to get my doctorate in physical therapy, and I graduated from there in 2018. I started my practice primarily in just general orthopedics. And it was during that time that I started to see some MVA patients or motor vehicle accident patients who sustained concussions as well. And I'm very much a person that if I don't know how to do something, I'm going to figure it out. And I remembered very little bit from PT school that we covered about concussion. But it was after that first patient that I was like, I really don't know what to do with them. And I started to look for more information. So some of my first continuing education courses right out of graduate school were in vestibular management and concussion management.
Okay.
And it really just showed me that I really like that area. I know a lot of people that end up in this world are people who have sustained a concussion. I'll knock on wood and say so far I have not. I have had family members with concussions, but really it was just, I find the brain amazing. I don't like the inpatient setting, so working with concussions allowed me to stay outpatient while still working with the brain. So yeah.
I have actually sustained a concussion, as have every one of my family members. So I'm excited to kind of tap into that a little bit today and get your perspective, both for me as a clinician, but also as a parent. So tell us on that note, right? I'm fortunate enough to where both my children, having played sports, have sustained concussions, but the majority of concussions the symptoms will clear within 7 to 10 days, correct? So kind of if you could kind of describe to us who ends up with you, like for those that have the residual symptoms that don't clear, what's the typical course of the pathology for them, and what's the kind of referral process to you?
So I'm so happy you asked me this question, primarily because the 7 to 10 days, I'll just say symptom recovery is very different than full recovery from a concussion. So a lot of times we'll see that symptoms will clear pretty quickly. A lot of times in that 7 to 10 day mark, especially if they are full brain development. So usually around 30 years or older, or if it was their first lifetime concussion. Usually that's when we see like things will clear up pretty quickly. That being said, average recovery from a concussion is actually a lot closer to 28 days. And I actually see people that take actually a lot longer than that for things to clear up that are beyond symptoms. So I'm talking things like ability to do multiple things at once, coordination, reaction time, things like that actually take a lot longer to recover than just symptoms themselves. So that 7-day mark actually primarily came out of back when we didn't know much about concussions and we were just really had no information about how to manage them. And that was really in specifically a football timeline where we have a game and then 7 days later we have another game. And so they would put players through this structured set of steps in order to get them to see if they were feeling good enough to get back in the game. So again, valid for the timeline and the information we had back then. The difficult thing is that as we've gotten more information, That hasn't necessarily been as updated globally as I would like it to be. Again, so I'm seeing more that 28 days is kind of the average recovery. And then again, a lot of those other things will linger past that. So in my opinion, if there is an athlete, and again, in the opinion of, I shouldn't say just my opinion, in the opinion of anyone in the rehab of concussions world, any athlete who sustains a concussion should really be screened by a rehabilitation professional. They can be screened within 24 hours after the injury. But essentially what that allows us to do is that allows us to see if there are any things that would lead to a prolonged recovery. If there are, then we just start to address them, and likely they will fall within a couple week to 4 week recovery that I would expect to be normal. If we don't see the athletes, then there is something that is potentially lingering. We could potentially see a symptom recovery that happens much sooner than we would expect, but they may also just be compensating for something. So if they compensate visually or balance wise, then later on down the line, if they were to sustain another injury, it then just stacks on top of that one. Even if they don't sustain another injury, they may feel like they're just still off and they're just not performing the way they used to following
Right.
that head injury. In which case then they would come in and see me, and then it's hard to break those habits. Once the brain develops a pattern of doing something, it is so difficult to break it and then retrain it. So I say I will see any athlete 24 hours after, because I would rather start from square one, avoid them developing bad compensation habits, and then just hopefully again ease them in much sooner. Um, so yeah, so that's what I would like to see.
Okay.
The
Yeah. In your
reality.
ideal world, right? In your utopia
Exactly.
vision. Yeah. Okay.
Exactly. The reality is that resources are still relatively limited. I'm fortunate in the clinic that I work in is that I've developed this program here. So I have it structured, and what a lot of my marketing has been is that I want to see them soon enough so I get them out of here quickly. So my schedule has stayed fairly consistently open such that I am able to see athletes within 24 hours, or at least within the first week of them sustaining the injury. Um, but if that is not the case, then typically a physician would look at seeing like, okay, after 2 weeks, if after 2 weeks they're not feeling better, then we definitely want them to go see a rehab professional. So in areas that the accessibility to get in very quickly is just not available,
Right.
usually they look to say like, okay, how are you doing after 2 weeks? After 2 weeks, if there are still some symptoms, that's when they say, let's go to rehab. Let's take a look.
So I have some follow-up questions to expand on that then a little bit.
Absolutely.
It's when, when there has been that delay, typically when you're getting referrals from the physician, have they had any other imaging, testing, that kind of thing? And even if they have, how useful is it, I guess, to you? And then if you could, again, just for our sports concussion rehab novices
Mhm.
in the audience here, like me, what does your screening typically entail? Like, what are you looking at, or what are you hoping to tease out?
Sure. So if once they are sent to me, very rarely do they have any imaging. So a concussion will not show up on any medical imaging. If they do anything, it's usually a CT scan or an MRI, and it's within the first 24 to 48 hours.
Right.
After that, and that's really just looking for a brain bleed. So after that point, if they were to do any imaging, very, 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 very rarely is it actually going to show anything.
Right.
Um, so what I look for more is like red flag symptoms. So if someone starts to complain of a headache that's just been unrelenting or has been getting worse, suddenly they're vomiting uncontrollably, any severe changes in mood, changes in orientation to time, place, anything that we would consider like this, something seems wrong here, then we would send them back for imaging if they haven't had any yet. Um, the other thing too is that if there is a significant neck injury involved, I usually want some sort of imaging to rule out neck fractures or upper
Right.
cervical instability. Um, but other than that, imaging really isn't that useful to me.
Right. That's
And
what I figured. But yeah.
yeah, and I've had a lot of parents come in very concerned about that, and they're like really pushing, like, no one did any imaging. We need that. We need
Yeah.
that. So a large part of my role is just educating them, like, if you're not waking up in the middle of the night with like a severe headache that's unrelenting, if you're not suddenly getting sick very frequently, like, I'm not too worried about it.
Right. And there's no need to throw away $500 to $1,000 for an MRI that's not going to show anything in most cases, right? Yeah.
Correct.
Okay.
And
Yeah.
for a person who's concussed, being in that tight of an environment with that much
Sure.
noise is
Yeah,
not
there's
going to
that
be
too.
pleasant.
Right. Yeah.
um, so when they come to see me, I, as a physical therapist, am looking, a lot of times people think I'm just looking at dizziness or balance. It actually goes a lot further than that. So it is under my scope of practice to look at the vision system.
Yeah.
So I was just explaining this to a patient actually earlier this morning. So I don't look at visual acuity. You go to see your eye doctor for that. I will maybe sometimes include visual acuity in a test, but what I'm looking at is vision. And vision is your body's ability to, or your brain's ability to process what you're seeing. So can you take the images in your outside world and actually process them into things? So if I hear people complaining of word finding difficulty, of like looking at something and just not being able to say what it is, a lot of times that's actually linked to a vision problem because they're just not visually processing, and therefore their brain's not able to then produce explanations for what it's seeing because it doesn't know what it's seeing. So I look a lot at that. I do look at the vestibular system. So for anyone listening that doesn't know, vestibular system is one of our three balance systems. We look at vision is a balance system, our sensory system, our ability to feel where we are in space, so like our feet on the ground is one, and then your vestibular system. So vestibular system is in your inner ear. It's also, there's a part of it in your brain. So if that is malfunctioning, that can lead to symptoms of dizziness, loss of balance, just poor spatial awareness, so symptoms like that. So I look at those two things. I also look at the cervical spine to see if there's any contributions to headaches. The vision system and the cervical spine are also closely related.
Yep.
So especially for someone who's had persisting symptoms and is maybe seeing me 2-3 weeks or months out from their injury, very frequently if there's a vision problem, there's also going to be a neck problem. And then for my athletes, I look specifically at dual tasking ability. So can they do multiple things at once?
Yeah.
Coordination, reaction time, and I'm just looking at things much more dynamically. How are they moving? And are they moving the way that an athlete at whatever level they're at would move typically? So
And
yeah.
for those clinicians, Caroline, that
Mhm.
don't look at visual system regularly, just to kind of delve and dig a little deeper.
Mhm.
I assume you're looking at like nystagmus, saccades, visual convergence, all the, the basic things along that line. Anything else that, again, people in the normal PT realm might not be as familiar with that you
Yeah.
typically tease out?
Yeah, so it's primarily those. So I'm looking for pursuit movements and I'm making sure that pursuit movements are nice and smooth and coordinated.
Yep.
I'm looking for saccades, which is our quick eye movements. We use it to read is a good perfect example of that. There so I'll look at that and making sure that it's as quick as it is, that it's not provoking symptoms, it's not provoking any dizziness. I also look at the VOR or vestibular ocular reflex. So that directly links our vestibular system, which I mentioned, to our ocular system, and is really just can we stabilize an image while we're moving through our environment.
Right.
And then yes, vergence. So I will specifically say vergence, not convergence.
Sorry. Yeah.
Um,
See, I'm showing my ignorance here. Yeah. In fact,
no.
I was thinking as you're saying this, I'm so old that concussion rehab wasn't even a thing when I was in PT school, it didn't even exist. So
Well, don't date yourself too much. When I
yeah.
started, when I was in grad school, concussion was like maybe an hour out of the
Yes.
entire 3-year curriculum. So,
Yeah. Yeah.
um, but yeah, no, so vergence over just convergence. So convergence is the ability to keep an image as one as it moves very closely to you. But we've actually found that it's more important to make sure that we can keep an image as one, not just as it comes close to us, but as it moves away from us.
Okay.
So vergence is just our ability to have our eyes work together.
Got it.
Convergence is moving close. Divergence is moving further away.
See, there we go. I knew I was going to learn stuff already, right? Yeah,
Yeah.
it's as promised, right? It was
Perfect.
already worth the price of admission here today. Yeah. So, all right, awesome. So, tell me, obviously, there's different levels of medical care within schools and a lot of the athletes you see, right? Um, Tell me something about well, first off, I'm wondering how many of them, and I don't need a definitive percentage, but how many do you see come in with baseline testing? And of the baseline testing, we know like impact testing is the name brand out there. I know best testing used to be a thing also. So if you could just give us a little bit of insight into baseline testing, how useful is it for you? How common is it out there? And what type of testing are they getting, in their local schools or that kind of thing?
Yeah, sure. So, schools with more funding typically do the baseline testing a little bit more.
Yeah.
I will say that specifically in Rhode Island, I'll just plug the Brain Injury Association of Rhode Island, for a
Okay.
second. They will help provide baseline testing for schools. The schools just have to know to ask for it. Um, it is beneficial. I will say it is beneficial. What it does, so concussions, unfortunately, they are getting very, very close to finding true biomarkers that they can just do a blood test and say, like,
Yeah.
yes, you have a concussion, or no, you don't. And once that finally comes out, that will be amazing for those of us
Huge.
that
Yeah.
manage concussions. Yeah, that'll be huge. So that being said, baseline testing is very beneficial in that it does allow me to see what did you look like before. So I largely base a lot of my clinical exam on just the overall clinical picture, as a lot of times we do as rehab professionals. So again, all those things that I mentioned in my previous answer, I'm looking at all of that, as well as what is their description about how they're handling just their normal day to day. And I compile all of that together to help me decide, are they still experiencing a concussion or not? But the reality is that sometimes if I have a kid who just has really bad balance and has just always really had bad balance,
Right.
like I'm not going to be able to look at a balance test and I can say
Yeah.
like, okay, compared to other kids your age that are playing the same sports that you do, that have had the same experience in the sports that you have, this doesn't seem normal. But the reality is that that may be normal for that kid. So, um, yeah, it would just, I think baseline testing just allows me to have a little bit more security in what I'm looking at when I see a patient. That being said, because a lot of it is done, like you said, through impact, and I'm not by any means going to say impact is wrong or impact is bad,
Yeah.
but I think there are ways we can do it better. Impact is a seated test. It's on the computer, and unfortunately, a lot of kids, just with the culture of concussions currently, they will intentionally do poorly
Yeah.
on that test when they sit down to take it, because then they know if they get injured, they're more
Right.
likely to either perform at the same level or a little bit better because they
Yeah.
intentionally performed poorly. Um, so there is a new one that's been coming out over the past few years, Sway Balance. It's actually an app and it goes through almost my entire clinical exam, but it's much more dynamic. So I've been encouraging, I was actually just speaking with the Brain Injury Association that I do think that there is some benefit into looking more into that as well, just a more dynamic test for kids to be able to say like how are they moving versus just how can they sit and perform this computerized test. So um it, it is beneficial. It is beneficial. But again, with the use of some of these specific tests, like I don't necessarily have access to the results. So
Right.
again, like I think that it's just more like we need to reshape it, but we don't need to get rid of it. I do know some schools are like, ah, it's a waste of time. It's a waste of time. It's not a waste of time. We just need
Right.
to reshape how we're looking at them and how we're conducting them. So I've actually started through University Orthopedics. I've started trying to do just like a quick little community outreach in the we offer free exams before participation in sports every year. So I've just been doing a quick little outreach and all I look at is a tandem gait.
Okay.
So that's walking heel to toe.
Yeah.
And then I compare that time to a tandem gait while they're also doing a very simple math problem or potentially telling me the months of the year in reverse. So I'll usually either do count backwards from 100 by 7
Yeah.
or months in reverse. And then I compare the two times. And that's actually been shown in research that if there's a greater than 10-second difference between the two, then there's a very strong likelihood that there is a dual tasking coordination concern there. So something as simple as that, it takes me like 60 seconds per kid. And
Yeah,
something as simple as that is like so helpful for
still
when
very
they come
useful.
back
Yeah.
in. Yeah.
And you don't have to pay the licensing fees for impact testing and yeah, right.
Correct.
So yeah.
Or sway balance, to be
Or
perfectly
so
honest.
yeah, right. Okay. Yeah,
Yeah.
great. All right,
Yeah.
excellent. So I'm going to piggyback and segue based on what you said with the
Yeah.
underreporting.
Yeah.
As a male, I'm pretty sure I can safely infer that a lot of the people that are underreporting symptoms are males. So tell us a little bit, if you could. I know there's some research coming out on gender differences and influence of that on recovery with concussion symptoms and that kind of thing. So if you could just give us a little bit of insight there.
Yeah, absolutely. So, um, the research that is coming out is actually fascinating. So what we've been seeing largely and what most of the research has been showing is that females are actually more likely to sustain a prolonged recovery compared to males. And there's a couple of different factors in that. Um, I would like to say that underreporting is not one of the factors. I can't say that it's one that's been researched, but I
Right.
mean, you said it. I can't say that that's not possibly the case. But no, largely what they've been seeing is that it's more the hormonal fluctuations. So as females enter puberty, depending on where they are in a menstrual cycle, will actually change what their recovery is. So there's
Yeah.
actually certain hormones are more protective in the brain. And when there's a drop in that, we'll see that if they were in that stage of their cycle, that they're more likely to sustain a prolonged recovery. And then so that's the primary gender difference. The other difference is more extrinsic to that, which is that female sports teams less often have an athletic trainer on staff.
Right.
So if there's not an athletic trainer on staff, then there's probably more head injuries that are not noticed right off the start. And then, or if they are noticed right from the start, then they're more likely to be mismanaged, potentially put back in a game when they shouldn't have been. If it's one that was not even noticed and they just kept playing, if they were to get another hit to the head or a hit to the body during that game, then that's one of the key indicators to me that they're going to sustain a prolonged recovery. If a kid comes
Right.
in and says, I got hit in the head, I went back in, I got knocked to the ground, I can pretty much sit there right there and be like, you're going to be seeing me for a bit.
Yeah.
Um, so that is definitely part of it as well. But what this newer research is showing is that they looked at males and females and essentially if they sustain a concussion and then immediately following the concussion get the appropriate treatment for the symptoms they're showing, for whatever their presentation is, if they get that treatment that they need, so pulled out of a game, put into a safer environment, educated properly on not going to like cocoon therapy or anything like that, seeing a
Yeah.
rehab professional, getting their proper clinical diagnosis, and then getting that managed, we actually see a similar recovery between males and females.
Okay.
So the question is less of, like I said, there are some intrinsic factors, and that's primarily hormonal. Um, but it's more on the extrinsic side. So what is it that we can do to make sure that they're being managed appropriately, equally? Because then in theory, they should be getting a similar recovery. So
Along those same lines,
mhm,
I know there's some research out there about recovery timeframes for those people,
mhm.
patients that are affected that are kind of neurotypical that may have ADHD or learning disability issues, those kind of things. So, are you able to touch on that a little bit as far as how that impacts concussion recovery or even the rehab?
Yeah, definitely.
Okay.
So any sort of learning disability, specifically they look at ADHD, dyslexia is one that I get
Yeah.
quite frequently. And yeah, anything like that, it just increases your risk of prolonged recovery. It does not necessarily say like you are guaranteed to have a prolonged recovery, but it definitely increases the risk of one.
The
So
likelihood. Okay.
yeah, and a lot of people, honestly, like ADHD is so prevalent
Yeah.
nowadays, that again, it just speaks to what I was saying when we first started, that I just want to see like all of these kids, especially athletes. I want to see them like 24 to 48 hours after that injury. Because then if they are dealing with that, it will allow me to see how some of the things piece out that could then lead to that prolonged recovery, and we can address them much sooner.
Sure.
And so they won't develop those bad habits. I have seen a couple patients with autism as well. I don't know too much about the research on the relationship there, but I can tell you from my clinical practice that it just, following a concussion, um, kids want to be out of a stimulating environment. They want to be in a
Yeah.
very close, quiet, calm environment. And so for someone who's already um, predisposed to wanting to be in that environment, it can sometimes be difficult to piece out, like, are you overstimulated because of the concussion, or are you overstimulated due to the autism? So that's been an interesting one for me clinically to kind
Yeah.
of work with, and I'm definitely interested in learning a lot more about that specifically. So yeah. And then dyslexia, I've spoken with other professionals who have also done vision treatment, and so like neuro-ophthalmologists, for example. And there's a lot of discussion out there. I don't know that there's formal research yet, but there's just a lot of discussion out there that um w- are some of these learning disabilities, ADHD, dyslexia specifically, that were always just underlying vision issues. And so if
Oh,
there
okay.
was always an underlying vision issue, so again, like I said at the beginning, if we are not visually processing our world, bad input is going to be bad output. So if we're not visually processing our world, our brain doesn't know how to interpret what it's seeing. Um, so therefore our output is bad. So maybe there needs to be more of a ocular motor screen that happens before kids enter school, that happens along in conjunction with the diagnosis of some of these conditions. And we just feel that the vision system, the ocular motor system, are just an under-observed system. So yeah.
Yeah, that's interesting.
Mhm.
Um, so you've kind of outlined your screening and eval process.
Mhm.
If you could walk again for like the novice, that may not be as familiar,
Mhm.
walk us through like what would a first treatment session look like for you? Obviously, it's going to depend on the findings and that kind of thing,
Mhm.
but how does it look as far as how long you're spending with each patient, what type of activities you're doing, that kind of thing?
Sure. So when I finish my exam, my clinical exam, I will group my patients into a specific clinical profile, and very rarely is it just one. And we're looking at headache, autonomic nervous system, which is actually something I'm surprised I haven't touched on yet. Um, so
Maybe it's
that's
poor questions from the host. I'll blame it on that. Yeah. So.
That's okay. Um, so headache, autonomic nervous system dysfunction, cervical spine, ocular motor system, vestibular system. So I'm going to group them into one of those. And like I said, it's very rarely one, but I'll usually have like, this is the primary, and then have like a couple secondary or tertiary ones.
Yeah.
So then when they come back for their first follow-up, I pretty much hone right in on whatever that primary one was.
Yeah.
So say, for example, their primary was ocular motor. So I'm going to focus most of my treatment on the ocular motor system. However, the ocular motor system is also one that fatigues very quickly. So if
Mm.
I work on the ocular motor system for a short period of time, I will then take a break, and the break will usually be something in one of the secondary or tertiary clinical profiles. So that way we're working a different system. All of those systems, despite that not being their primary clinical profile, will still impact their ability to function within that primary clinical profile. So even if I saw very, very, very little vestibularly, for example, I
Yeah.
will still work through some vestibular exercises in order to just help. Again, that will help with the vestibular ocular reflex. It will help with just overall navigation of their environment if their ocular motor system is not working where it needs to be. So I typically spend, depending on the patient, my goal is like 50 minutes to an hour with every patient. And then I only see them once a week. So
Okay.
what that does is that allows me to spend more time with them. So that way I can pace it such that if they are overly symptomatic one day, I will have them do a little exercise, and then we'll take like a 2 to 3 minute rest. Um, if it's someone that's closer to the end of their recovery process, or one of my high level athletes that I see, we spend a lot more time just doing like high level, high function, just exercises.
Okay.
And we may not need as much rest, but now I'm looking at what's their endurance like? Are they able to endure doing these tasks over the length of essentially an hour? I will say I'm not always successful in getting a patient to 50 minutes to an hour, especially some
Yeah.
of my acute patients. We may only make it through 30 to 40 minutes, but
Sure.
yeah. And then, like I said, once a week, primarily because um unlike some of our more orthopedic injuries, our brain is always on. It is
Right.
always on. It is always functioning. So if it's one of my student athletes, they're not just doing rehab for a concussion, but they're also a student. So they also have to save some reserve to be able to perform whatever they need to do as a student, studying, going to class, things like that. Um, so if the more that I take away from that reserve throughout the week, if I was to see them 2 to 3 times a week, it's not going to make them better any faster. It's just going to fatigue them more.
Right.
So yeah, so
Oh,
that's
makes perfect
primarily where I
sense.
go.
Yeah. So then tell us, like in between sessions, what would their home program look like, Carolyn?
Yeah, so again, it goes based on whatever their clinical profile is. So I have some very, very simple exercises that I call building blocks. And a lot of times it's just an element of whatever my exam is. So if it's
Okay.
ocular motor, I might just have them do very simple saccades.
Okay.
If it's more vestibulospinal, so more balance oriented, I'll just have them do like tandem balance, eyes open, eyes closed. So very simple things.
Okay.
And then more of what my home program is about how to manage that, like, brain's energy availability throughout their day.
Sure. Yeah.
So take a high school student, for example. They have, say, 6 classes, 5 to 6 classes in a day. Each class is about 50 minutes. And then they have like 5 minutes of passing time. So just as an example, I will literally talk them through, like, okay, your home program is you're going to go to class for 40 minutes. Then you're going to go to the nurse's office for 10 minutes and you're just going to sit in a dark space and you're going to just rest. And
Yeah.
then you're going to go to your next class. You're going to go to class for 40 minutes. Then you're going to go to the nurse's office. And we just kind of work through whatever it is that that kid needs in order to facilitate that endurance and increase that overall energy reserve. So that way they don't get to lunch period and they're already migrainous, dizzy, and just want to go home.
Yeah. Right.
Um,
And I should have probably asked you a little bit about the pathology, but I mean that energy reserve in the brain, like one of the primary things affected, right, is glucose use in the brain after that trauma, right? Which
yes,
is
yeah.
takes a
So
while to kind of yes.
So, it's actually, so like I said to start, there's no structural, like visible structural damage. There's potential for some neuronal shearing as the brain moves, but there's no like bruise to
Right.
the brain, or there's no like notable damage. So what actually happens is a major chemical shift. So we see this just cross blood cell chemical shift. And as a result, the brain is essentially just out of homeostasis. And
Yeah.
so it wants to get back to being in homeostasis.
Sure.
So in order to do that, yes, we're relying on ATP pumps to be able to just bring things back to where they should be. And then that just requires a ton of energy, right? So
Right.
it's just, we do see some vasoconstriction, and then with the vasoconstriction, obviously we're not getting resources to the brain as well. So therefore we have a little bit of an energy deficit. And then we also see that, again, like our brain is always on, it's always functioning. So once we see this mismatch that, like, okay, well, I'm trying to use a lot of ADP to get things back in balance, but I'm also putting all these normal demands on it, we don't have enough for both. And so once we
Right.
start to have a bigger mismatch, then we start to get symptoms, headaches, dizziness, nausea, fatigue, and things like that. So a very, very good indicator for me if someone is still dealing with true concussion pathology and not just an ocular motor issue, right? Because we'll get to a point where it's like, okay, are you still dealing with the concussion, or have you just created really bad habits for yourself? So
Right.
I'm looking
Yeah.
at someone like a year out, for example, right? Like in theory, that concussion, like that balance should be good again, but you've just
Yeah.
created some bad habits that are still causing you to be symptomatic. So when we get to that 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 state, I'm looking at like, okay, let's have you go for a 30-minute walk, come back, try to read a book for a little bit. If I've seen a normal ocular motor exam, that might be what I say. Go for a 30-minute walk, come back, try to read for a little bit, and then do your math homework. And if all other symptoms or all other systems look good, vestibular, ocular motor, things like that, if they become symptomatic with that, they just used a ton of energy to do certain things and they're becoming symptomatic, there's still probably a little bit of concussion pathology there. Not always are we going to see some of those other ocular motor, vestibular, things like that. So, yeah.
Okay.
I don't know if
All
that
right.
makes sense, but
No, yeah, absolutely. That was really well articulated and thankfully, simplified for somebody like me. So I appreciate that. Yes. Um, so tell us a little, you mentioned a little bit about what your education level was like coming out of school, and your introduction to sports concussion rehab. And I know, I've seen it even evolve from when I did my sports physical therapy residency back in the day. It's funny you mentioned cocoon therapy, right? So tell us a little bit about what you've seen as far as the evolution of concussion rehab and some of the philosophical changes or that kind of thing.
yeah. So obviously, like you said, way back when, we would see this cocoon therapy, which was just, and I mean, again, for the information we had at the time, it made sense, right? Which is,
Yeah.
the brain is fatigued. We need to rest it, and if we rest it, we then will be able to get back to things and symptoms recover and whatnot. But the issue with that was we were seeing that symptoms weren't recovering. There
Right.
were some people who were very lucky and they went through cocoon therapy, which is sit in a dark room, don't do anything, just sit and rest, sleep, things like that. So for some people that worked, but it was significantly lower percentage than the majority of people that were dealing with concussions.
Yes.
And so what we kind of realized with that is that this is the way that I explain it to my patients. The brain is a high level athlete, right? So we take a very high functioning athlete and I don't know, they sprain their ankle. And it's a pretty bad sprain. And we put them on bed rest for 6 to 8 weeks, right? That's like tissue healing time. So we put them on bed rest. And then because they're a high level athlete, we say, all right, well, you're better. Double sessions. They're going to feel horrible, right? Like they're not going to feel good at all. So the same concept can be put on the brain. So if we have this high level athlete and then we put them on bed rest, right? So we get a concussion, we put that high level athlete on bed rest. And then we say, okay, you're good, you're recovered, go back to full-time work, full-time school, test taking, driving, whatever other functions that it normally would, and people weren't feeling good, because the brain became deconditioned. It forgot how to do those things that it wanted to do, and it didn't have the endurance to sustain it. So when you look at the brain in that way, then we start to say like, well, maybe this is something we can also rehab.
Yeah.
Um, we know that a healthy brain loves physical activity, right? We've got brain-derived neurotrophic factor, which allows us to remodel the brain, create new neural pathways, things like that. That is largely pumped out when we are physically exercising.
Yes.
It increases blood flow to the brain, right? And one of the issues that we have is getting enough energy to the brain, enough ATP to the brain. And so, if we exercise, we increase blood flow, we get more of that to the brain, which is then going to help it function better, right? So then we take a sick brain or an injured brain and we apply some of those same principles. And suddenly we start to see, okay, well, people are actually feeling better after their injury. So
Yeah.
now we look at it more literally. Like I tell people that come to me and they're like, how do you rehab a brain? Like, how do you rehab the brain? I'm like, the same way I rehab a knee, the
Yeah.
same way I rehab a meniscus tear. Like, you've been dealing with this pain. Let's do things to what we can tolerate because we want to keep
Yeah.
things strong. We want to keep things working around it. We don't want to just unless it's indicated via surgical intervention or whatever, we don't want to just be on bed rest, right? We want to be keeping things strong around it. And we've noticed better outcomes in orthopedic injuries with that approach. The brain is the same way. Let's not just have it rest. Let's work on some of the functions that it normally would do. We'll just rein it back a little. We'll do like 15 minutes of reading instead of sitting to read for an hour. We'll do, I don't know, 10 minutes of a video game instead of sitting for 3 hours or
Yeah.
whatever it is, but little doses of things. So that's slowly been coming up every couple of years. There's this big group that sits down, all medical professionals working in the concussion world, and they come up with a consensus statement on how concussions should be managed. And the not this most recent one, but the one before that was really where we started to see the implementation of rehab for a concussion. And it wasn't until this year that now there was actually a physical therapist who was one of the lead authors on the consensus statement. Kind of, again, just pushing that rehab process into the forefront. So yeah, it's been cool to watch.
Yeah, that's awesome. And honestly, hugely appreciate it because personally, when I sustained my concussion a long time ago now, it was still in the cocoon therapy days. And I can remember having a primary care sports trained physician tell me that my exercise should be walking the dog. I was like, nah, walking the dog. I'm like, that's a chore. That's not a fun exercise. Like I want something to push it a little bit.
Yeah.
So, but there was like this trepidation about anything that was going to provoke symptoms, right? You couldn't push it to that threshold. And now it seems like the philosophical trend has been like, pushing to that envelope, right? Kind of reaching that threshold is not terrible. A little bit of stress is actually a good thing, right?
Yeah,
So,
absolutely. Like I said, it's just like rehabbing any orthopedic injury.
yeah.
I tell patients constantly, I'm like, don't be afraid of your headache. Don't
Yeah.
be afraid of getting dizzy. If you're like dizzy falling over, like, okay, we probably
Sure.
pushed it a
There's
little
a
too
line.
far.
Yeah.
But like if there's just like a slight symptom increase, like that's not a bad thing. That's a good thing.
Yeah.
Yeah.
So piggybacking on that, for any
Mhm.
parents listening, and who knows, I mean, the only listeners might be you and I, and maybe your family members, but
Yeah.
for anybody listening that's a parent, what would you tell them to look for in identifying cooks? Because there's still this, I guess, mystique around concussions about, is it a concussion? Is it not? Is it safe for the child or patient to go back to sports? So tell me, what should people look for?
Yeah. So we have a tagline in the sport concussion rehab world: when in doubt, sit them out. So
Yeah,
if you think it could have happened, just give them 24 hours. Just take them out of the game, let them sit for 24 hours, because sometimes like you could see it happen and they get up and they seem fine, and that's because they're playing in a high intensity game and there's a lot of adrenaline.
right.
So if there's the possibility, so that's what I say. So first and foremost, mechanism of injury. So if you see something happen and you think it could have been a concussion, take them out. So mechanism of injury, they don't have to be hit in the head. I will scream that from the rooftops. You do not have to be hit in the head
Right.
to get a concussion. It could be someone bumped into them really hard. Even if they stayed upright, someone hit them hard enough, created a little bit of a whiplash through the cervical spine,
Yeah.
they could have sustained a concussion. Knocked to the ground is another one. Again, even if they didn't hit their head. That being said, hitting their head is also a very good sign.
Sure. Yeah, right. Yeah.
But it doesn't have to be the only sign. So looking for any big force through the body, it would be mechanism of injury. So from there, again, if you saw it happen, it looked like a pretty aggressive hit. Your gut says you're not sure, pull them out.
Yeah.
If you feel pretty good and it seems like, okay, well, let's take a closer look at this. So, onset of headache, dizziness, light sensitivity, noise sensitivity, vomiting. Those are some other key ones that are like, okay, they're pretty likely that they did
Yeah.
sustain a
Cool.
concussion.
Right. Yeah. Right. Yeah.
Seeming dazed. So like asking them like, what's the score of the game? what period are you in? Something about like the situation and like how quickly can they respond. If you are asking them questions, it doesn't have to be that specific, but if you're just asking them general questions like, how are you feeling? Are you doing okay? Are they pausing before they respond? So again,
Yeah.
just seemingly dazed. And then sometimes too, like the parents can't necessarily run out onto the field, right? Or the
Right.
parents aren't
Yeah.
necessarily at practice. They're just seeing it from a distance. And I've
Yeah.
I've talked to parents that are like they're just watching and they see the kid talk to a trainer, talk to a coach, whoever, and then they get up, pat them on the back, and they go back in. But then the parent can see, right, that they're
Yeah.
like maybe
Off.
stumbling, they're
Right.
moving
Yeah.
slower, they
Yeah.
just seem confused on the field. Parents can absolutely go up to a coach and say that they want to pull their kid. And that's perfectly valid thing to do. Um, and I would like to see more of that, to be honest with
Yeah.
you.
I'm sure. Yeah. Right.
Yeah.
No doubt. So this has been awesome, like hugely instructive and educational. Couple kind of follow-up questions here. For anybody hoping to get into sports concussion rehab, are there any specific resources or places you would direct them to, like for any therapists listening?
Yeah, sure. So even if you just want to learn more about it, even if you have no interest in practicing it, um, I love MedBridge. So that's where I
Okay.
started. Well, I shouldn't say that. That's not where I started. I started in North American Seminars, they had two seminars. They had one on vestibular rehab, one on concussion management. Um, those aren't run as frequently, but they were done. It was Becky Bliss, who is out in Missouri now, I believe. UMiss, I believe, is where she is. Dr. Bliss, I'm sorry if I spoke wrong about that. But I'm pretty sure that's where she is now. So she is great. She again instructed me through North American seminars. After that, MedBridge. So any PT who
Okay.
has a MedBridge account looking for specifically Ann Muka and Sue Whitney. So they're both out of University of Pittsburgh,
Pittsburgh, right? Yeah.
at their medical center. They're huge concussion rehab facility in the country. They have one of the what I call the original concussion doctor, Dr. Mickey Collins.
Yeah.
So he's great. So MedBridge, they both have a couple courses on there. So that's just a good, like, very simple starting point.
Okay.
For someone who wants to delve in really deep,
Yeah.
Concussion Corner Academy is where I got the meat of a lot of what I do. So it's just Concussion Corner Academy. It's a kind of hybrid course. Some just you're doing it on your own, some in virtual, but live Q&A sessions. They were about 40 hours each, I think, over the course of like 3 or 4 months. But what I loved about it was, oh, what's the word I'm looking for? Multidisciplinary.
Oh, right.
So I
Okay.
learned from PT, AT, a special education teacher, an occupational therapist, a neuro-ophthalmologist, a neurologist. Um, so in that, especially Rhode Island, resources are limited. So
Yeah.
being able to have little bits and pieces that I can pull from other toolboxes that allows me to, like, if I can't get someone to a specialist immediately, I can at least start them down the right path while they wait the month or two to get into a specific specialist if they need something. So,
Yeah.
yeah, I would say that was
Especially
huge.
since the impact is so diverse, right? I
Yeah.
mean, as far as
Mhm.
the considerations with concussion recovery. So,
Mhm.
um, tell us, for anybody listening that's hoping to kind of get more information about you or get in touch with you, where could somebody find you on social media or contact info if you could?
Yeah. So, my sport concussion rehab program is through University Orthopedics. So people can always contact me directly through University Orthopedics, specifically the physical therapy department. So they can always reach out to me there. Number can be found online. And then I am on Instagram primarily with just a little bit of outreach as UOI Concussion PT. I will be honest, I've been super busy this past sports season, so I've not been as good at posting.
Yes.
But
That's
I
all
do
right.
have a decent backlog of some educational information on there. Once this podcast goes up, I'll kind of link this there as well. And then, yeah, hopefully with the summer, with school sports kind of slowing down a little bit, I'll get some more
Yeah.
information up there too.
That's what I was gonna ask. You probably have a little lull,
Yeah.
at least a month or two before things really like ramp up again, right? So,
Yes. Yeah. Yeah.
so
Fall through April, pretty much. I'm crazy. And then
yeah,
I hit summer and it's a little slower. So,
that's good. Yeah, you get to enjoy it, truthfully, right? So I lied. Apparently, I am gonna spring a question on you because
yeah.
give us one interesting fact about Caroline that cannot be found on the University Orthopedics website? Like what's something, any personal interests, any hobbies, any, other interesting facts about you?
Yeah. Probably why I have never sustained a concussion, again, knock on wood, is because my primary sport is running.
Okay. There you go. Right. Much
I'm a
safer,
marathon
right?
runner, so as long as no one trips me, I should be in the clear.
Yes.
But
And
yeah,
even if so, now your vascular health and brain health is much better, right? So you'll
correct.
you'll recover quickly, right? So
Exactly.
awesome.
Exactly. Yeah.
All right, excellent. Well, thank you very much. This has been awesome.
Yeah.
Hopefully, it proves helpful for you as well. And we will get that information out there, and I'll let you know as soon as the podcast is ready.
Perfect. Yeah.
All
Thanks,
right.
Dan. I really appreciate it.
You're very welcome. All right, take care, Caroline.